Right. So can you see the slide now?
Yeah, clearly.
So this is the learning objective.
Yeah.
We think of the different microvascular complications that can occur with diabetes. I'm going to look into why these complications occur, and then we think about how they're treated, okay? And obviously, this is all common knowledge that poor diabetes control causes damage to the blood vessels. So they cause both micro and macrovascular complications. So I thought I'd start off with just a case to work out how you would think about managing such a patient, okay? So this is a 50-year-old individual. He's male. He's had type 2 diabetes for 20-odd years, and you see him in your practice for an annual diabetes checkup visit. So what areas would you be thinking about in your annual checkup visits to address?
Quite a few things. Basically, we'll have to make... Can you hear me?
Hello?
Can you hear me?
Actually, shall I put the microphone on? That's easier, isn't it? No?
Yeah.
Or if you put it up, because your thing's louder than mine.
Yeah.
Yeah.
What?
So I still can't hear him clearly.
So he can't hear you. Or
He can hear me. I can't hear him that clearly.
that clearly.
Yeah.
Well, we can increase the volume on this one.
Whereas I can hear it through his speakers there. So he's clear on your computer, isn't it?
Okay, we can give you the speaker.
Yeah.
That's not an issue. Get that. There you go. Just plug it in.
Or through his computer.
But then it doesn't explain the situation.
Hmm. Can you say something again?
Can you hear me now?
Yeah, this is
Yeah, see, it's not that. Do we have his phone number?
I can hear you. Hello? Hello? Voice is gone. Hello? No. No. I can't hear you. I can't hear you.
Hello?
Yes, I
I
can
can
hear
hear
you.
you. Perfect.
Good.
There you go.
Right.
No.
Good. I can hear you now. Hello?
Yes.
Yes, that's better. Thank you. Sorry about all this. So we've got a patient, 50-year-old type 2 diabetes for 20 years. And what areas would you think about checking in the annual checkup visit?
Well, when it comes in like medication compliance, blood sugar
Yeah.
level, monitor the blood sugar levels. What is HbA1c level? Then
Yeah.
for retinal screening, has he had any annual retinal screening?
Yeah.
Checkup. Also, has he had regular bloods to check his kidneys, blood pressure?
Okay. Yeah.
Those are the main things I would.
Okay. And probably lipids as well. I don't know if you. Yeah, lipids. So if I can move forward the slide, sorry. So that is what we've got on him now. So his blood pressure is 150/90 on bendofluoride. You've got an HbA1c which is poorly controlled at 9% on metformin. You've got his cholesterol. He's not on cholesterol tablets, but also you've you've done a protein to creatinine ratio which shows he's got microalbuminuria. He's got pre-proliferative diabetic retinopathy and peripheral neuropathy. So how would you think about addressing all of that to prevent his microvascular complications getting worse?
One thing is that his blood pressure is still high and he has got microalbuminuria. I would start on ACE inhibitors for blood pressure and to protect the kidneys.
Yeah.
And also his HbA1c is slightly on the higher side.
Yeah.
I would increase it to 1 metformin 3 times a day.
Okay.
And also he is not on any statins. I would know his blood. I can't. Where is his total cholesterol? I can't see his total cholesterol.
So let's say his total cholesterol is 6.
I would start him on statin.
Yeah.
And because he has got pre-proliferative diabetic retinopathy, I would send him to refer him to ophthalmologist.
Okay.
He's also got peripheral neuropathy. We should also deal with that also.
Okay, great. So the talk is going to focus on some of the evidence regarding that, but also how we look at microvascular complications, because now you guys are seeing more and more of the patients with type 2 diabetes. So these are patients you will see on a regular basis in your practice, yeah? The other thing that everyone tends to forget, I'm sure you wouldn't in clinic, is smoking. Cutting smoking really helps with cardiovascular disease prevention. But I think one thing that we don't do properly, and certainly I don't always in clinic, is to think about complications of diabetes, which patients may not offer straight away. So erectile dysfunction is a very common symptom that a lot of patients don't report to us. And actually we can think about ways to improving that by controlling glucose control and blood pressure control, but also thinking of medications to improve that. So Viagra, obviously, and sildenafil, what can be prescribed on through the community. And there's also a psychological aspect which needs to be addressed in these individuals as well. Yeah. So I just was going to talk about the different areas of microvascular complications, so the eyes, the kidneys, and the nerves. And do stop me if you want any clarification as I go along, okay? So, in terms of microvascular complications, to try to prevent it, we have to think about the severity of hyperglycemia. And there was this study from America, which was quite a landmark study, because before this time, no one really knew whether controlling glucose levels would improve the long-term microvascular complications. So this was a type 2 diabetes trial looking at patients with different degrees of HbA1c, and it's found that as your glucose got worse, your risk of having retinopathy, nephropathy, neuropathy increased dramatically, okay? And actually, if you reduced it, as we now know, your retinopathy, nephropathy, and neuropathy complications got better. Now, that was in America, but in the UK, there's a really key study which I would really advise you to look up, the UK PDS trial, which again replicated this. And if we concentrate on the microvascular changes, again, as HbA1c increased, the incidence of microvascular disease increased as well, okay? As well as macrovascular, but we're just focusing on micro at the moment. So that's one thing we should think about. But another thing is hypertension has a direct influence on microvascular complications. So again, from the UK PDS trial, this showed that the type 2 diabetes patients who had the worst blood pressure had the worst incidence of microvascular disease. And actually controlling blood pressure made the risk of microvascular disease much, much better. But there's also other factors we should think about. So people can be genetically predisposed to having microvascular complications. There's something called hyperglycemic memory. Do you know what that is? Or yes, so it's interesting because let's say if you saw a patient with type 2 diabetes who's had type 2 diabetes for 10 years, now if that patient's glucose level at 10 years is brought back down to the normal range, that patient will still have more worsening microvascular complications as someone else who you may have seen 5 years earlier whose control you suddenly got better, okay? So actually treating these people quite early on will prevent a lot of the microvascular changes later on. And it doesn't really matter how good your control is later on. If you don't pick them up early enough, they will still progress to having microvascular changes. Yeah. So this is a paper. If any of you are really interested to work out how glucose can cause damage in the kidneys, the eyes, and the nerves, and I will leave you to read that to look through how it happens. But from a clinical point of view, I'm now going to go through diabetic retinopathy, okay? So diabetic retinopathy is actually the main cause of visual loss in patients with diabetes, and it's actually the main cause of blindness in people of working age. Again, another paper if you really want to work out the mechanism behind glucose and eye problems, and you can read that up. But I thought at this stage I will ask you a question to think about how we would look at our patients with diabetic retinopathy, okay? So which one of the following statements is true regarding diabetic retinopathy? Is progression unrelated to glycemic control? Are cotton wool spots a feature of background retinopathy? Are hard exudates always treated with photocoagulation? Is maculopathy threatening to direct vision? Or are proliferative changes best left untreated? So which ones of those do you think is correct? Hello?
Direct vision, yes. Those are the two things which are correct. Others are hard exudates can be treated by.
Oh, you're cutting out. What? So which one? The hard exudates you think is correct? Hello?
Full spots are feature of.
Okay.
Maculopathy.
Yeah. So actually, the only correct answer is maculopathy can threaten direct vision. Okay. The rest are incorrect, and I will go through it in the talk with regards to why that is. So just to put it into context, this is our normal eye. So you can see the optic disc there, and you can also see the macula, and the macula is very important for color vision. Okay, so the optic disc is located medially and lateral to that is the macula. So that's one of the eyes. This is another eye, again showing the optic disc and the macula here. Okay, so the first change, you can't.
Now I can.
Can you see it? Okay. Can you see my pointer? Hello?
You won't be able to see only with that screen, so the pointer needs to be there.
Can you see the pointer here?
No. Can you?
Hello?
He's probably disconnected.
Hi. Can you see the pointer?
I can hear you. Yes, I can.
Okay. So this is the optic disc. Yeah?
Yeah.
And this is the macula. Okay?
Yes. Yeah.
Here. So the first change is background retinopathy. Okay? Now this is very common in our patients with type 2 diabetes, and after 20 years, probably the majority of our patients, over 95%, will have background changes. Okay? And these are classically known as hard exudates, and that's because the myelin sheaths release the lipid content, and so they look very cheesy in color, very yellow in color. You can also get microaneurysms, which are the vessels which get very, very dilated, the capillary vessels, and they can leak and cause blocked hemorrhages. So these are the classical features. So this is again another eye. That's your optic disc, and this is your macula. But you can see all of these cheesy dots here. Yeah. So these are the hard exudates. Okay. And you can also see, if you look at the vessels here, yeah, sometimes you can have dilatation of the vessels, like here, okay? And when they dilate, you can get these dots called hemorrhages, okay?
Yeah.
So those are all background changes, okay? So that's background retinopathy. Now, pre-proliferative retinopathy is where the vessels become ischemic. So these are when cotton wool spots appear, and they're very fluffy areas, and they represent retinal ischemia. So again, with the eye, you can see the soft exudates here. Okay, they're very fluffy in nature. And again, here you've got the optic disc, and these fluffy areas. They're different to hard exudates, which are very crisp. These are more like, they're called cotton wool because they look more like cotton wool spots. Okay, so that's pre-proliferative change. Now, proliferative change is when you get new vessels forming, okay? And these can occur anywhere on the retina, and they can occur in haphazard fashion. They don't follow normal routes where the normal vessels go. And wherever they appear, they can threaten the vision because you can't see because all these new vessels appear. So again, this is the optic disc, but can you see all these vessels just appearing haphazardly? Yeah? So this can threaten vision, and so it really needs to be dealt with urgently by the ophthalmologist. Okay? And these vessels can actually go onto the optic disc and cause problems here with sight. Okay? So that's the third stage of diabetic retinopathy. Normally background changes, then you can get pre-proliferative, and if they're not treated, you can get proliferative changes. Again, these haphazard vessels being seen across the retina.
Yeah.
So maculopathy is basically when you get hard exudates near the macula. So if I remember, the macula is where you have your color vision. Okay. Now the hard exudates can occur, as I said, in background changes. So if they occur in background changes, they're not really anything you have to worry about. But when they occur near the macula, that can threaten vision. So that's quite urgent. So that's why in the original question, right at the start, the question was, is maculopathy threatening sight? Well, that's true. Okay. So again, this is where the macula is, and you can see all these hard exudates at the area of the macula. Okay, so management. Before I show that slide, do you know the management for background retinopathy?
Basically, and also for your photocoagulation.
Okay, so actually background changes can just be followed up on an annual basis. Okay, so not all of them will progress to pre-proliferative changes, but we have to warn our patients to improve their glucose control, and then also warn them that they need to look out for any problems with their vision. But really, the annual retinal screening will follow these patients up, and the majority of them will just have background changes for the rest of their life. It's only the ones that glucose control is very poor or they are hypertensive that they progress to having worsening microvascular disease. Yeah. Now, pre-proliferative changes, because they suggest ischemia, if you leave them alone, they will progress to proliferative change. So these individuals really need photocoagulation, okay, which you were mentioning before. And proliferative changes, now these need urgent photocoagulation because these new vessels occur haphazardly. If they go around the optic disc, it can threaten your vision very, very quickly. So actually, background changes, just annual review, Pre-proliferative changes, they need to be seen by an ophthalmologist, but that can just be a routine referral. Whereas if you see someone with a proliferative change, that is an urgent referral. Okay. I don't know if you've seen patients with photocoagulation. Oh, we've gone back. Sorry, photocoagulation. But this is the eye again. This is the optic disc. You can see the vessels are very haphazard. So this is probably someone with proliferative changes, and you can see the vessels here all blasted away with the laser. Okay, so these are very classical changes of photocoagulation. And the whole aim is to prevent new vessels from forming. Okay, to prevent the eyesight getting worse. The vessels can't be reversed, so the proliferative change can never become pre-proliferative or background changes, but it's to prevent any worsening of the vision. Yeah. Do you see? I mean, in your practice, do you have a retinal screening at all?
No, we send to a particular center in Darlington. They do a
all right.
training.
And do the reports come back to you, or does it go to the ophthalmologist if there's a problem? It comes back to you. Okay. So probably it's very interesting then for you to work out how to actually deal with the changes. Okay. So maculopathy, the problem with maculopathy. Oh, sorry. I can actually stop. I can stop and do the others next time I'm here. Actually.
Yeah. We have another one
at 2 o'clock. Okay, fine. Well, let me just finish the maculopathy side. So maculopathy, when you have problems at the macula, then really what you need to do is think about photocoagulation only at that site. Okay, so only at the macular site. So you don't need to have pan photocoagulation, you can have grid photocoagulation. So what the ophthalmologist does here, can you see the grid here? There's one area of photocoagulation here, and that's where all the...
Yeah. I can't see the picture.
Can you see the picture now?
Now, yes.
Okay, so there's a time lag. So again, you've got the optic disc here, you've got the macula, and you can see this area here, which is a bit like a grid where the laser beams have targeted. So unlike the other ones where they were all over the retina, this is just targeted here. Yeah. So that's it. So what I was going to do was to talk about diabetic nephropathy and peripheral neuropathy as well. But what I will do is for our next webinar, I can carry on the talk because it looks like our IT problems means I'm being told to stop now because you've got to talk from, is it cardiology? Yeah, cardiology after. Okay. But I hope that was useful.